Heba Barakat, Healthcare Programs Manager at AUC School of Business Executive Education. I hope you are all keeping well and staying safe during these testing times. It's an honor to welcome you all to our webinar today, which is a part of our Business Reconfigured series, Healthcare Track webinars we are launching in the upcoming period, including COVID-19 healthcare quality preparedness from standards to implementation on the 25th of June, and COVID-19 infection prevention and control on the 2nd of July. You can join by registering through the Executive Education Facebook page or the Executive Education website. Before we begin our webinar session today, I would like to share some engagement tips that would help enhance this webinar experience. Please keep your microphones muted so we do not experience any noise distortions. Please do not open your camera or start a video so we maintain a smooth streamlining connection. We have ample time at the end of the session to answer all your questions, so please park all your questions till after the session so they are structured comprehensively and in relation to the entire discussion. During the question session, if you have any, please write it in the chat box addressing Heba Montasser. We want to stick to the time designated to this webinar and wrap up at 8:30 p.m. today. Today's webinar session will be on University Hospitals Leadership in Time of COVID-19. It's my pleasure to introduce the AUC University Counselor, Professor Ashraf Hatem, who is going to introduce our esteemed speakers. Dr. Ashraf, the floor is yours.
Thank you very much, Dr. Heba, and good afternoon, everybody. I think the university hospitals is something which is very important in the healthcare profession, not only in all over the world, but especially in Egypt. And the university hospitals, as many of us know, it has very important roles in education, training of all the healthcare professionals, in research, especially the clinical research and the clinical trials and clinical guidelines, and also in provision of healthcare services. Actually, maybe in Egypt, the healthcare provision in the university hospitals have traditionally, since many years ago, 100 years, more than 100, now 200 years, the university hospitals have been providing healthcare services for the people of Egypt. And as for now, we have about from 15 to 20 million patients who are attending to the university hospitals. In Egypt, we have about 113 university hospitals all over Egypt. Of course, they have different levels and in all governorates, and they work hand in hand in provision of the healthcare services with the Ministry of Health and the private sector. Again, the university hospitals in Egypt its role have been there is a reform of university hospitals, and the new law for university hospitals was just have been there since 2 years. And the role of university hospitals in the COVID-19 pandemic, I think we will have a discussion about it in very few minutes. I'm very pleased to have our two distinguished speakers today. I'll leave Professor Mahmoud, I'll speak about him now, but from Geneva we have also Professor Tarek Shaarawy, and I'll say his bio after when he will start to speak. But I'm very pleased to introduce my dear friend Mahmoud Meteini. Professor Mahmoud Meteini, not only is the president, of course, of Ain Shams University nowadays, and this very important times for the healthcare profession at all, but he is a professor of hepatobiliary and liver surgery, and he is the head of the liver transplant unit. He's a very famous surgeon for liver transplant, and he's the director for liver transplant unit and founder of it in Ain Shams University. Mahmoud is not only a practicing surgeon, he is a researcher and he is an administrator. He has a multitask job, and he's doing this very talently. And Mahmoud was the Dean of Faculty of Medicine in Shams University, and now he is the head of Shams University. I say it is one of the biggest universities and oldest universities in Egypt, of course, after my own university, Cairo University. Now I'll give the floor to Professor Mahmoud Meteini to give his talks about the university hospitals, especially in this time of COVID-19 pandemic. Please, Dr. Mahmoud.
Thank you very much, Professor Ashraf Hatem, my very dear friend and ex-Minister of Health, and for the very generous and kind introduction, and I hope that I deserve these words. And thank you for the AUC and the HEBA and the managing team and all the higher administration and the AUC for organizing this very important, I would say, event this very important time that we are all witnessing since the beginning of the pandemic, some 4 or 5 months ago, at least in our part of the world. I had been asked by the AUC administration and Professor Ashraf Hatem to speak about the Ain Shams University impact at this very important point of time that the world is witnessing, having been hit hard. There is no country in the planet that has not been hit hard by this COVID-19 since the end of 2019 and also till now, and we don't know till when even. And of course, everybody is taking all the measures possible, and we in Ain Shams will try to mitigate as much as possible the effects of the COVID-19. My agenda today is that I'll start by recognizing the COVID-19, if it is a flu or not, and I'll go very rapidly on the Egypt numbers and touching on our challenges that we are all aware of in our country, and then going a little bit in detail in the Ain Shams University measures to mitigate the COVID-19 effects at many levels, at the administrative level, at the healthcare, at the research, and at the service. And I'll end by how can we imagine life after the COVID-19. The famous question that have been raised over the past few months, is it a flu or not? And the answer is clearly probably not. It's not usual flu, and it's for a humble surgeon like me to say such an open statement in front of Ashraf Hatem, the most famous chest specialist in this country. But I said this because of the data we're seeing in this slide on the left panel from the WHO, giving the numbers over the past period that we are approaching 8 million cases worldwide with around 500,000 fatalities. And if we compare it by the data from the same period of time in the right panel, that it's true that the numbers are much higher, reaching some 50 million or so instead of 8 million, but the fatalities is at least 10% only, 50,000, 40 to 50,000 fatalities. So the fatalities in the same period of time from the COVID-19 is at least 10 times more the usual flu. And that's why we answer this question by probably not, because it's a very highly infectious virus, rapidly spreading, and up till now, we don't have a specific treatment. What about Egypt, and how are we managing this problem in our country? Egypt, as you all know, is a big country with a population of surpassing 100 million. And as you can see on the right side, the most populous area in Egypt is Greater Cairo, the Delta region, Alexandria, and down to Sudan, all around the Nile Valley. The healthcare expenditure has been always a challenge, but over the past few years, we took some, and according to the new constitution, We have a 4%, a little above 4% of the GDP as a healthcare expenditure. And of course, we can elaborate a lot about fragmentation of this expenditure later on during the discussion. And when the COVID-19 started, President Abdel Fattah al-Sisi allocated immediate 100 billion Egyptian pounds for the COVID-19, which is literally 50% of the annual expenditure on healthcare. And we have to remember some facts here that we still have, in spite of all the progress we're trying to do over the past few years, at least 30% of Egyptians are below the minimum wage threshold, and we still have around a little above 25% of illiteracy. I'm stating these two important facts just because home isolation is great, and maybe the Western is not convinced by the term of isolation or the term of quarantine as a better term, quarantine hospital, but we need it in this country because of these two facts. What measures have we taken in Egypt and maybe in the world? As you can see, this is a very long timeline with multiple stations. I'm not going to go through all of it, but I will stop at the 5 important stations with the red circle. That is the first, or the index case in Egypt was on the 14th of February, and the first fatality was on the 8th of March. And I don't know if we can hide this. Yes. And suspension of the education facilities was on the 15th of March. And successively, the 19th of March, the aviation was suspended. On the 21st, the mosques and churches were closed. And on the 26th, we started for the first time the overnight, or the what we call the partial nationwide curfew. And we're supposed on the 13th of June here, 14th of, at these days, to start a gradual resumption of the normal life with a lot of challenges. And I'm not sure, again, this is the point to discuss later on a lot. What is the COVID situation in Egypt? The June outlook was that the curfew hours will continue. The mask became mandatory for everybody, even those who are in the private cars, with a fine of up to 4,000 Egyptian pounds for those who are not wearing, and with aiming at a gradual resumption of normal life, but with the slogan of stay home, stay and save lives is still continuing. And if you look to the April, May, and June, the numbers are growing and they are picking up, and we didn't reach what we aim at, the very famous curve, the Bell's curve, without protective measures, and the blue one flattening of the curve occurred with going down in numbers, which is this blue curve all the countries is aiming at. We didn't reach this level yet, we're still picking up, and we'll see what can we do to flatten the curve first and then go down in the numbers. As of just 48 hours ago, these were the numbers. We are approaching the 50,000 cases in Egypt, with around 1,500 cases a day, sometimes 1,400, 1,500, 1,600, around 1,500 cases a day, approaching 2,000 fatalities, which will constitute around 4% of the total number. So are we prepared now to make a total opening and the total resumption of the economic activities? We're all aware of the challenges and the economic challenges and constraints that we're living, but I think it needs a lot of reflection. We here in this country are very much aware of our challenges, our habits and norms. We are very social people. We love social gathering. We love to sit together, and all this have been restricted and will stay restricted for a while. There is a problem of awareness. I just gave you the figure of illiteracy in our country. There is a lot of concern and panic by the employees everywhere. And we were concerned about a PPE shortage, but fortunately, all institutions in Egypt have made a lot to overcome this shortage, including ours, as I will show you shortly. Interrupted medical supply chain because of the travel bans. We are aware that many of our medical supply are imported, so there have been travel bans. Testing issues, availability, cost, mass versus targeted testing, and nobody can argue against the conflicting, we're just talking about that, the conflicting data. It's very conflicting data, very rapidly changing. You have from the top authorities in the world, medical authorities in the world, the CDC, the WHO, the Lancet journal, you have a piece of information that next day is being retracted or being said in a reverse way. So there are a lot of conflicting data that is disturbing the medical community. Testing strategy, the graph or the panel on the right side show a list of countries with topped by the UAE. I don't know why Switzerland is not here, because I think it ranks second after the UAE. But as you can see, Egypt is at the bottom of the list with around, it's a little bit more than this now, it's around 100, a total of 140,000 tests being done until the 17th of June. This was a national rate of around 1,400 per million. But we in Shams, I think we did a good job in that since the beginning, end of February to date, we did around 36,000 PCR that constitute around 25% of the nationwide testing. And we just started the drive-through lab 48 hours ago, as you maybe heard about. If you see this, this will be clear in the couple of slides later, that when we calculate how many patients were taken care of, and we calculate the 36,000 PCR, we found that we're doing some about 12,000 per million. So Ain Shams alone will be between Iran and Colombia on the right panel. We try to analyze because we're doing this analysis in two labs, the Ain Shams Specialized Hospital Lab and the Demirdash Lab, and 30,000 of the 36,000 were done in the Ain Shams University Specialized Hospital Lab. And when we dig in the details of it, we found that around 89% of these tests were for an age group between 20 and 60 years, and the minority whether below or before 19 years or above 60 years. And the number of tests per month were doubling, as you can see, from March to April to May, and the first 10 days in June it's doubling, and this is expected to be around 21,000, maybe tripling. And when we look to the percent of positive cases, again, an exponential increasing from 1.7% per month to around 30% per month positive cases from the total number of cases done per month. A little bit about Ain Shams University history. It's, as we heard from Professor Ashraf Hatem, it's the third in terms of timeline. It's the third university in Egypt after Cairo University, Alexandria University, and then Ain Shams University that started in 1950. But we believe that Ain Shams University goes back to 2,700 years BC, and under the name of Own University, because Own University, according to the history, existed in the very same place that is in Abbasiyya and in Ain Shams and in Matariyya, where now this is the place where Ain Shams existed, and Amhotep, the famous pharaoh, graduated from this Own University. So very proud of trying at least to go back to as old as the 2700 BC. In 1950, Ibrahim Pasha University started, and in 1954, immediately after the 52 revolution, the name has been changed to Heliopolis University, and in the very same year, the vision by that time that to choose Arabic names, so change the name to Ain Shams University. Where are we in terms of international ranking? Ain Shams is ranked by all ranking bodies in the world, the QS, the Shanghai, the Times Higher Education. And as you can see, it's somewhere between the 600, 700 Shanghai and US News, but between 800 to 900 according to QS and Times Higher Education. It's not up to our ambitions, but there are a lot of challenges, because we believe that we're having a good research product and research output, a good education, a good reputation, but we have our challenges that I'll be happy to discuss it later on. But in terms of ranking by subject, I think we're doing a better job here. As you can see, the pharmacy between the 200 and 250, and agriculture in the best 300, medicine and engineering in the best 350. Ain Shams is equivalent actually to a small city. Why we're saying that? It's comprising 16 faculties and 3 institutes. But at the beginning of the pandemic problem, we realized that in Ain Shams you must take care of 3 million persons plus an unknown numbers of COVID cases. Why we're saying that? Because we have an Ain Shams University staff or faculty around 15,000, an administrative body huge, around 40,000, and 250,000 students. 100,000 undergraduate, 25 postgraduate, and 25,000 blended, what we call blended education. So if you add all this up, you will end up by 310,000. And if you imagine that every member of this 310 within Ain Shams University have a family of 3 to 4 persons, then you have to be concerned with 1.2 to 1.5 million. And as has been mentioned in the introduction, that we are receiving we are one of the biggest university hospital with 4,000 beds, fragmented between 2,700 in Demirdash, 1,000 in Ain Shams University Specialized Hospital, both in Abbasiyah, and the remote small hospital in Abur in Eastern Cairo, around 250 beds. This big facility is receiving 1.5 million patients per year. So if you add all this up, you speak about 3 million. So it's really a small city, maybe larger than any city in Europe. How many doctors are serving this population? 4,500 doctors with a ratio of 15 per 10,000, which is similar to Egypt, around 14 per 10,000, and of course lesser than what's in the USA, around 26 per 10,000. How many bed per 1,000 population? We're around, if we count only the 3 million, we're around 1.3 bed per population, which is not far from Egypt, 1.6 bed per 1,000 inhabitants, and US around 3. So the question always, do we need more beds, especially in the current situation? And we'll see that. So this is the history of the Demirdash Hospital. I just put it to tell you that although Ain Shams University started in 1950, officially the Demirdash Hospital back to 1928, set by a generous grant, a charity hospital by Demirdash Pasha and his wife and his daughter. What's the impact and what did we do in Ain Shams University? I'll go by timeline. In 25th of February, we did a huge awareness campaign, both internally within the campus, in the 16 faculties, in the 3 institutions, administration, everywhere, and externally in the surrounding area and in Eastern Cairo and wherever we were asked to go to make people aware about the COVID. In March, in the 15th of March, the education had been suspended and the students at home. We downsized our elective surgery and outpatient clinics on the 17th of March, and we started the telemedicine triage on 23rd of March. In the 1st of April, we declared the first university quarantine hospital, which is the Abur Hospital. And the vision behind that, we didn't want to disturb the usual medical practice going on and serving our patients in the main campus in Abbasiyah, the main big campus. So we chose the remote one. We were thinking by that time that it might be enough. On the 4th of May, we introduced our dorms because there were no students, only for asymptomatic positive cases and mild cases. Anything above mild cases were not admitted to the dorms and needs a hospital. And still the numbers is growing, as you are witnessing day after day. So we introduced our geriatric hospital on the 7th of June, our old emergency hospital on the 9th of June. And just 2 days ago, all of us witnessed the first ever field hospital in Egypt, as I'll show you shortly. Raising awareness by, as I said, awareness campaign within and surrounding community, telling everybody what is COVID-19 by our infection control team, public health team, family medicine. We are blessed by our doctors that went all around the country for telling everyone what is COVID-19, how do we get infected, what is the mode of infection, how to avoid infection, and advising everybody to stay safe at home and working from home. And this is one of the videos that, if you allow me, will take around 50 seconds, that have been broadcasted all over the media and all over the television channels and the social media.
أنا أيمن صالح أستاذ القلب مدير مستشفيات عين شمس الجامعية. إحنا كلنا بنشتغل عشان صحتك وصحة أسرتك. من فضلك خليك في البيت.
شيماء مشرفة تمريض بمستشفيات جامعة عين شمس. أنا عارفة أولادي فين، أنت أولادك فين، خليهم في البيت، من فضلك خليك في البيت.
أنا يسرى تيسير استشاري الأمراض الصدرية. ناس كتير ممكن تموت هنا. ساعدنا نقلل عدد ضحايا الوباء. تحمل المسؤولية، أدي دورك، انقذ روح غيرك. من فضلك خليك في بيتك. من فضلك خليك في البيت.
أرجوك خليك في البيت.
أطباء وممرضين كتير يضحوا بحياتهم علشان نساعدهم. انقذ حياتك وحياتنا، خليك في البيت.
This was being followed by massive disinfection campaign, as you can see in the lower panels. Everywhere, all the classes, auditoriums, labs, everything on a regular manner and ongoing manner since the beginning of this pandemic. And adjustment to working condition by several internal decrees that appeared weekly, maybe decrees. All measures that all went online, as you can see. For example, in the middle panel down here is the university council, all meetings, the departmental council, the faculty councils, everything went online and working from home. Even the students were at home. I will not speak here about the education because there are a lot have been done on this distant learning, but it's out of scope of this talk. And we started PPE manufacturing, which I told you about our concern about the shortage of PPE. So we're starting PPE manufacturing, whether at Demirdash or Ain Shams University Hospital, to fill any gap that might happen. And this is a decree that I issued obliging everybody to wear a mask whenever he returns to the campus. Telemedicine, our telehealth program, we were blessed that it started back in 2016 by the Treat and Teach initiative. And the vision by that time is wanted to treat and teach remote areas, underprivileged areas like in Red Sea, down in Aswan, in New Valley, in Marsa Matruh River. And we went our outreach in Africa to Eritrea, to Somalia, and to Nigeria. 2017, the virtual hospital was launched, the Ain Shams Virtual Hospital, and 2019, we extended the innovation arm to the Treat and Teach slogan, and we started early in January, February, our first spin-off company, according to the new law that has been issued last year of promoting the technology, the so-called rule number 18, or law number 18. So we're blessed that this service already existed. Of course, when the COVID-19 pandemic started, we made use of this in making the triage telemedicine, the COVID helpline, the COVID home monitoring. And as you can see on the right side here, this has been advertised on all the social media about the Ain Shams specialized hospital for telemedicine, and presenting all consultation, whether for COVID or non-COVID cases, online. And actually we do all the time surveys, and we have more than 80% patient satisfaction, around reaching up to 90% of the doctors were confident that their management online was right and on the right track, and we were serving 16 specialties. What about the Ain Shams University Hospital quarantine service? I told you that we started the first one in Abur Hospital that were in the beginning of the 1st of April with 70 bed and 41 ICU. And then just in June, beginning of June, we started the geriatric hospital, a 44 bed and 29 ICU, emergency hospital with a 40 bed facility and 20 ICU. And just 2 days ago, and today was the first patient to be admitted to the field hospital, the first ever, 165 bed and 11 ICU. So we have a total of 319 bed and 104 ICU. If we add the dorms, so of 480 bed for the asymptomatic and mild cases, so we are presenting a little below 800 bed with 104 ICU. And when we looked to the cases admitted over the whole period of time to Ain Shams University and served, it's surpassed the 1,500 cases. Most of them recovered and discharged with the PCR negative and in a good shape. And we have around 3.7% fatality. And we always raise the question, do we need extra beds at this circumstance and the difficult time? And the answer is probably yes. Why is it yes? If you look to the panel, the left-hand side panel, and this is the percent of suspected COVID-19 cases within our dedicated triage area in the Demirdash Hospital. And you can see the number per week here is picking up, as you can see, and it's reaching from 3 to 4 to 5% in the early weeks to now around 35 to 40% of the weekly visits being suspected cases of COVID. And this will take us that yes, we need maybe more number to serve Ain Shams, but also to serve the Greater Cairo and Egypt. And this is how the field hospital looked yesterday. Again, we try to introduce some institutional guidelines in terms of consensus statement on the management from the Ain Shams team, and a pocket guide for the management from the Ain Shams team and our Ain Shams protocol, and the home isolation booklet, both in English and in Arabic, trying to simplify that and make it at the fingertips of everybody who was working in Ain Shams or the community. Frontliner safety, I think this is of paramount importance. You have to make our doctors and nurses that are really concerned about themselves, and they are so right to do this. We want them to relieve them and to send them a message that we are really taking good care and keeping an eye on them. So we took the decision that I think has not been taken widely, even all over the world. We were one of the first to do that, to screen all healthcare, all frontliners and healthcare workers at Ain Shams University Hospital. So we screened the 4,040 healthcare worker, all registrars, and by all I mean all, even if it's not serving the COVID service, all SHOs, all house officers, all nursing and technicians, by both rapid test and real-time PCR. And the idea behind that, we want to identify the hot spots within the campus and then to react accordingly. And as you can see in the panel on the right side, our rate of infection was 4.2%, which is not very high and expected in a big facility like this, with around 96% non-infected. And when we dissected our infected cases, we found that the majority, 2/3 were asymptomatic and only 1/3 of them were symptomatic, with the highest number, of course, in the nursing, around 60%, and in doctors, around 26%. Research, I think research is very important. We are all witnessing in the medical facilities around the world and the universities and the medical community, a very fast track research path that we never witnessed before, and for obvious reasons, of course. But beside the clinical research, we did a research consortium, and this was my decree 3 months ago, to put together the medicine with the engineering, with the computer science, with the pharmacy, with the basic science, because apart from the clinical trial, we need to build as rapidly as possible a simple ventilator, and to add multiple apps day after day to better serve our patients. But in terms of clinical trial, we had a very fast track approval from our IRB in Ain Shams for in 3 waves. The first wave was 7 clinical trials, followed by 9, followed by 16, and they are all registered on clinicaltrials.org. And they explored many things, exploring the genetics of the strains of the COVID, and whether we have one strain or more in Egypt, the healthcare worker screening and risk assessment I just mentioned, preventive measure in terms of BCG, for example, and treatment, the Avigan and the plasma that we collect from the recovered patient, if it is beneficial or not, at least in severe cases. And we were supposed to be with the Ministry of Health hospitals in the Solidarity trial raised by the WHO in Abur Hospital. And the latest study is one from psychiatric comorbidities, whether in the patients or even the healthcare workers. Emergency no-show. One of the things that really alarmed us, that when we put COVID aside and we looked for the number of emergencies that you used to have every day. Yes, we downsized our outpatient clinic. Yes, we downsized by ourselves the elective cases. But what we witnessed is that the emergency cases are always also going down. And this is a paper that has been published recently by our neurology department, showing nicely that the number of cases or stroke cases in the pre-COVID area versus the same period of time in the post-COVID area, as you can see, 40% less cases, patient took less time to reach the ER, the cases were more severe, hence more aggressive management, meaning that the patients are refraining from going to hospital and ER because they are afraid of contracting the COVID. And I think this is universal observation. And what we witness also that this is an ICU, empty ICU. So this is not the one dedicated for the COVID, but it's a usual ICU that used to be packed in the pre-COVID area, pre-COVID time, I'm sorry. How do we anticipate and how do you see life after COVID? I think it's a very difficult question. We did this pamphlet on the right side, which is the safe going resumption and what we call Dalil al-Awda al-Amina lil-Amal. And this has been printed only 2 days ago, and we are going to distribute it to all our administrative body that are supposed to return at one point of time in July or August or whenever. And I think the most important, the second point is to reimagine care pathway. We stopped a lot of surgical intervention services and many usual and our banality or our usual medical practice. So if we're going to go and do 100% resumption of the activity, how are we going to do that? Are we going to do PCRs for all patient, every patient admission? What if they contracted in the post-operative period, sometime the COVID? What will be the plan? What will be the pathways? All this is being reimagined, and with a lot of discussion in every specialty with our friends from around the globe. Integration of more and more technologies and more apps and more distant learning and more distant telemedicine, creating an ecosystem is of paramount importance. A value-based care, outcome-based assessment versus the current fee for service model, what we call a connected care, which I'm sure that in the West it's already established maybe, but in our part of the world it needs a lot of work, a lot of infrastructure, internet facility that is available but not as fast as we need it. And this very important statement that came from Chelsea and Westminster Hospital, and I would like to quote it, that they said that unless we seize the quarantine in an organized, gradual and structured manner, the COVID effect on the health system and the world economy would be casually lethal, claiming for far more victims than the virus itself for years to come. And I would end the slides quoting Henry Kissinger in the Wall Street Journal when he said that the coronavirus pandemic will forever alter the world order, and with some unanswered questions that we would be happy to discuss it later on with all of you. Is a COVID, is it a natural or man-made? And it's still an unanswered question. When do we achieve a herd immunity, or when do we find the vaccine? I hope shortly and not too far from today. When would families meet again? And are we witnessing a World War III effect with the merging of new superpowers? The answer may be yes. I will stop here. I would like to thank you very much and be happy to answer any question.
Thank you very much, Professor Mahmoud. I think there are a lot of questions, as you said. If COVID-19 is something which is man-made or accidentally made by man, we will, maybe we will know afterwards or not. I think you have put a lot of questions which in the future we may come to answer. And again, of course, Ain Shams University under your presidency have responded very promptly and well to the COVID pandemic in Egypt from the first day. And Ain Shams was the first university to open a university hospital. And at that time, the Ministry of Health was saying that we don't need the help of university hospitals. Nowadays, after several months of that, all the university hospitals, or many of the university hospitals, we have more than 20 university hospitals now on the ground, but El Abour and then the other sister hospitals in Ain Shams and also the domes in Ain Shams University have been the place where many of our patients have sought the service which they didn't find anywhere else. I think this is very important. And what about the university hospitals all over the world? especially Geneva. I visited Professor Tarek Shaarawy in his very fine, very elegant Geneva University Hospital several years ago. And Professor Tarek Shaarawy is the medical director of the Geneva University Emergency Center. He's the head of the glaucoma unit, University of Geneva, and he's the president of the International Society of Glaucoma Surgery. But he didn't, he has a lot of, as an author, a lot of textbooks in glaucoma and other things, but he had never forgot Egypt. And he is the Secretary General of the Baladi Foundation. And this is an NGO which serves patients in Upper Egypt. And I have seen the effect of this in Upper Egypt. I think Professor Tarek Shaarawy is a very important eyewitness to tell us what is the role of university hospitals in a country like Switzerland, the Geneva University Hospital, and the model. Professor Shaarawy, the floor is yours.
Good, so I'm unmuted. So thank you, Professor Ashraf, for the excellent and kind introduction. And thank you for the AUC for inviting me to share our experience with you. In 1986, I applied for the AUC as a student. I was accepted, but I think I could not, avoid the attraction of the Qasr al-Aini, the oldest university in the Middle East. So it's a great opportunity for me to join the AUC in this event. I actually come from the same natural habitat as Professor Mahmoud al-Meteini. We share our passion for the operating theater, and we are both part of university hospitals. He sits on top of the pyramid as a president of one of the best universities in the world, when I was plucked from my natural habitat as an eye surgeon to participate in this COVID response. So he has the advantage of being prepared when I was absolutely not prepared for what I had to do. A little bit about Switzerland. I live in Switzerland for the last 20 years, but I am a regular Egyptian coming to Egypt every month to work. And I've never lost my contact with my beloved country. Switzerland is a new country compared to Egypt, obviously established in August 1291 with a small population of 8.5 million people, but a GDP per capita of $82,000, which is the second highest in the world. It is a federation made of multiple states, or canton as we call them. It has 4 different official languages, and it's a direct democracy. What's a direct democracy? Direct democracy is that if I have to cut a tree in my neighborhood, the whole neighborhood has to vote on it. And if my army has to buy some fighter planes, the whole country has to vote on it to accept or not accept that the army would buy weapons. This is direct democracy. Now, what is the healthcare system of Switzerland? I think it's very important when we are discussing the response of COVID in Switzerland to understand how does this healthcare system. Well, it's a healthcare system that is based on that every person has to buy a private insurance from private insurance companies. All private insurance companies do not have the ability to say no to a citizen or a person living in Switzerland wanting an insurance. So we have to buy, and they cannot say no. It is one of the highest costs in medicine, but it has, according to multiple parameters, it has one of the highest outcomes in medicine around the world. Life expectancy is the highest in the world, with 80 years for men and 84 years for women. And we put 11.4% of the GDP in our healthcare system. Now, if you compare that to Germany, we are very similar to Germany, and we have more or less the same kind of health indicators. So we come out more or less providing the same quality of care. The US actually puts 17.5 or 17.6% of the GDP, but has much worse outcome compared to Germany or Switzerland. So it's not always how much you put. It is also related to how you use the money that you put in the health system. Egypt, as Professor Mahmoud rightfully said, puts about 4% of the GDP And this is where I work. I work in the university hospitals. It has been established in 1602, 1,120 beds, 8 different hospitals, 12,000 people working there. It is the biggest hospital, university hospital in Switzerland, with more than 26,000 operations per year and about 700,000 of hospitalized nights per year. So one of the biggest, actually, hospitals in Europe, and definitely the biggest in Switzerland. And you can see this is more or less the landscape of our hospital. Now, it is very important to understand, and this I think is very important for you to understand how we are financing this hospital. We are financing this hospital 50% through the business, the medical revenues, all the procedures that we're doing, the services that we're doing. We're getting about 50% of our budget. The other 50% is a subsidy of the government. So the government is paying 50%, meaning if we only rely on ourselves to make money, then we will be 50% short. But through taxes, through subsidy from the government is providing 50% of that. So now we come to the crisis. Well, our first case was very similar to Egypt on the 25th of February. And our first death was on the 5th of March. And what is very different from Egypt is that we had a significant increase in cases over the first couple of weeks, where we went from 5-6 cases per day in late February to about 1,500 cases in late March. So the curve was extremely fast. In mid-March, the government decided to close borders, to close schools and universities, and to prohibit meetings of more than 5 people. And the only thing I think that saved us was that we started mobilizing in end of January. So we had 1 month to prepare for the storm, the hurricane that was coming. And I really thank God and thank our government for putting pressure on everybody to start preparing. Otherwise, I don't know how we would have met a challenge of 1,500 cases per day for a country as small as Switzerland. Now, Switzerland is very much at risk of developing a big problem, and that is because we have more than 300,000 people that live in another country and cross the border every day to work in Switzerland. So mainly from Italy and France, we have 300,000 people that cross the borders, they work and they go back. And basically what happened is that the Italians coming, especially from the north of Italy around Milano, basically our first cases were people coming from Milano and unfortunately infecting the population, as you can see here. Now, it's important to understand that in a country like Switzerland, where the rule of law is of paramount importance, you have to have a legal background or a legal base on which to act. And I think the government and the parliament was very clever. In 2012, they actually created an Epidemics Act. So a law specifically to be enforced when pandemics happen. And that's exactly what happened. When we had the pandemic in 2020, we took out the law from the shelf, opened it, and started applying the articles of the law. Having said so, not everything was perfect. This guy, Professor Koch, is our leading infectious disease expert. In the 24th of February, he said, probably COVID-19 is just as a flu. So this is probably an echo from many, many authorities around the world. I'm sure that you've heard a lot about situation like that. To his credit, Professor Koch later on reversed his opinion and became the face, the person that everybody in Switzerland put their hopes and aspirations in him, because he was running the show, more or less. From my position as an eye surgeon, I immediately noticed things changing. The first thing was the federation, the Swiss federation, the government took over. Now, this seems to you as something that is very natural, but we are used to local government. We are used to the Republic of Geneva. Geneva in itself is a republic and it has its own government. So the federal government in Bern taking over, this is unprecedented. I've never seen that before. And then we were ordered to cancel vacations, cancel congresses, stop any professional trips. and we were given liberal working times, not any longer from 8 to 6, but we have to work as much as is needed. And we were asked to work also from home sometimes if that is needed. So all the rules changed very rapidly. Now, Professor Mahmoud spoke a lot about the idea of quarantine hospitals. And this was discussed very, very briefly in Switzerland. This was a no-go. We were not going to quarantine anybody. We put in hospitals people that had moderate to severe conditions, especially people with acute respiratory symptoms, but we did not isolate anybody in quarantine hospitals. We took patients. People who were mild or tested positive with no symptoms were asked to auto-isolate. Now, please keep an eye on this to see the daily changes week by week from the week 9 to week 20. And you see this storm of cases that is basically, attacking everybody and is a huge burden on the health services. Imagine if a country as small as Switzerland started putting everybody that tested positive inside the hospitals. We would never be able to provide care for people that needed care. And that's why from the beginning, we only took people that needed to be hospitalized. And we kept our hospitals free so that we can care for those. And we also care for people that were self-isolating, and I'll explain how. Now, when you face a problem, you have to evaluate your assets. You have to look around you and see what is there, what can you play with. We have the university hospital, the ASUH, the Hôpital Universitaire de Genève. We have private hospitals. We have private centers. We have the Geneva Emergency Network. And this is a group of people that actually, group of doctors that basically those provide emergency care at homes. And then we have the federal resources, obviously including the army. So what the strategy that was adopted was relatively simple. Play with the full team. We are not going to work only with the university hospitals and leave the private sector alone. We decided that we play with all our resources from the beginning. And I think that was a key issue to our key decision. We also, the strategy of the government was to protect vulnerable population, elderly people, people that are immunocompromised. Those are the people that have to be protected because the mortality is highest among those. And of course, protect medical personnel, doctors, nurses, technicians, because if we have the best beds, the best ventilators, if we don't have the right people to actually work them, then there's no real point in doing anything. So protect vulnerable population, protect medical personnel, and play with the full team. And the full team, as you can see in the center, is the university hospital. And then you have the private sector and the Geneva Emergency Network. Those are three different entities. So we started immediately by end of February to move all our non-COVID cases to private hospitals, every single one of them. We moved over 1 week, 1,223 cases. That might not be big numbers for my fellow Egyptians, but remember that this is small Geneva. Geneva is 500,000 people. So we were moving a good percentage of the population, which are all patients that are hospitalized in the university hospital, to private sector. And that was a huge logistic issue and logistic operation that went very well. Then the university hospital freed itself completely for COVID cases. All operations that were not necessary was closed. My department, the ophthalmology department, for the first time in its 100-year history, we actually closed it with a key and left. There was nothing in ophthalmology. And we tripled the capacity of the ICU beds in 1 week. So in 1 week, we went from 120 to 360 ICU beds, all with ventilators. And our plan was to have the potential to not just quadruple, but go 5 times as big in ICU beds if needed. We never had to do that. At triple the capacity, we never were above 60% of occupation of ICU. And then we looked at our personnel. We have 12,000 people that we can play with. Now, those are mainly 54%, as you can see, are nursing staff, and 16% more or less are doctors. And those had to be divided into what is critical staff, you know, ICU doctors, ICU nurses, chest doctors, clinical pathology experts, anesthesiologists, all those were the golden boys and girls. And then there were people that were not critical like myself, a poor eye doctor that tried to find a way to help in all that. And we had our strategic reserves in the form of retirees, people who have retired recently, and we can bring them back to work with us. So it became very important that we have to visualize the problem. And in the words of the WHO General Director in mid-March, he said, "You cannot fight a fire blindfolded, and we cannot stop this pandemic if we do not know who is infected." So we needed to know who is infected. So immediately, a few days after we started the pandemic in Switzerland, we faced a terrible reality. The reality was that Switzerland had the second highest cases per capita after Spain. We were ahead of Italy, and we were scared of the Italian situation where people will die in streets before going to hospital. So a plan had to be devised very fast to look at certain goals, strategies to apply them, objectives and tactics to succeed. So the goal simply was to dramatically and immediately slow the progression of the pandemic. The objective was to reduce mortality and morbidity, lower the death toll and the expense of people's lives from this pandemic. And the strategy was divided into two things: social distancing and test. Now, if we look at the strategy of social distancing, no more than 5 people can be in the same room. Close all commercial and official buildings, all of them, except supermarkets, police offices, bakeries, things like that. Close universities and schools. And interestingly, we had no imposed confinement or curfew. We were not asked by the government, we were not told by the government that if you come out, you'll be fined. We were not chased by police officers in the streets to push us back to our homes, like in France or in Italy or in Germany. We were actually asked politely to stay at home. And somehow people listened. Now, test is basically a tactic of liberal testing. Test as much as possible, especially in the beginning of the pandemic. Trace all contacts and then self-isolate individuals who test positive and isolate their close contacts. It's a simple tactic and simple procedure that many countries around the world did. Now, Professor Mahmoud spoke about numbers, and they add to you, sir, the Swiss numbers. So the United Arab Emirates comes as the world leader with 300,000 tests per million. Switzerland is by far after the Emirates with 56,000. And Egypt, according to the numbers I saw, was 1,320 per million. I think Professor Mahmoud spoke about 1,400. I don't think we'll have an issue between us about 80 persons difference. That shouldn't be a big issue. And from there on, we actually also had to look for our patients that were non-COVID cases. So non-COVID cases that were hospitalized went to private hospitals, as I mentioned. Patients that were ambulatory, we started contacting them, audiovisual with special software called ASUH at Home, where we could speak to our patients. Maternity, geriatrics, those are high-risk people that had special measures. I do not want to waste your time. Psychological support for everybody, for doctors, for nurses, for parents, for patients, for relatives, for young adults, everybody. And the government took very good care of the situation with cases of domestic violence, because we found out that in Paris, there was an increase of about 40% of domestic violence cases. So it's a very contradictory situation, because the victims of domestic violence are asked to stay at home when there's danger for them to stay at home. So there was an enormous upgrade in federal and local support for victims of domestic violence. Professor Mahmoud spoke brilliantly about their screening program, which is pioneering in every sense. We went in a slightly different direction, where we went for a population-based immunity study. We wanted to know how many people in the community would test positive. So it was a serological test with the help of this polyclinic. It's a mobile polyclinic that has 3 rooms 3 examination rooms. And we basically started running screening after screening. We repeated it 4 times over 6 weeks, and we went from 5.5 to 11% of seropositive IgG antibody immunity. So we are about 11%, by far fewer than what we 60 or 70% that we need for herd immunity. But we needed to know how fast is the disease propagating in the community to evaluate what is going to happen in the coming months, not just in the coming weeks. Now, it's a good time for doctors nowadays, I would say, in Switzerland. We are offered free food in the hospital. We are offered free parking. Just mind you, I'm paying $300 per month for parking. So for over 3 months, I saved $1,000. That's not too bad. We do not queue for supermarkets. Once you show your badge, you can go immediately in the supermarket. You don't have to queue. And at 9 p.m. every day for the last 3 months, the whole population will come out in windows and balconies and terraces to clap for all medical workers of Switzerland. If doctors are considered as heroes and nurses and technicians, I guess we would not have been able to do that without civil society. And the civil society did so many things in so many instances. But I cite to you 2 specific points. Well, the group of private banks in Geneva went all the way and negotiated with Chinese government. And it's a private sector, it's not the government. They bought 100 tons of medical supplies, and it came on the 30th of March, and we needed those PPEs, and we needed those masks and gloves, and we were saved by the civil society. Now, we have in Geneva one of the biggest, or actually the biggest fragrance company, the perfume company in the world. And they stopped all manufacture for perfumes, and they went on to produce 60 tons of hand sanitizers to help the Geneva population and the Geneva doctors, 60 tons. And that was produced in 10 days. We asked the army to intervene, and the army intervened after 10 days of the pandemic. They put field hospitals, they brought in ambulance. I was working with ambulances from the army as well, as I will mention. So the army was active, and they provided care all over Switzerland. This is the federal army of Switzerland. Now, my work in this story was that I was asked to do what they plucked from ophthalmology, and asked to do something to produce a care and to create a telephone front line for Geneva. Now, consider me as running the 144, which is the 105 in the Egyptian. So I was running the Egyptian equivalent of the 105. We called it COVID call, and people would call 144. And I was asked to reduce flooding to the university hospital. I was asked to prevent too many people going to the hospital, because our outpatient clinics and our emergency clinics could not cope if we keep on getting 500 people coming extra every day. So stop flooding and provide support for people that will be in auto-isolation. So people would call our unit and we would answer them, and we would basically distinguish between patients that need to go to the hospital by themselves, or patients that we send an ambulance to take to the hospital, or patients that we tell them, please, you are not a difficult or a serious case, stay at home and we will look after you. And I was asked to create a working group and to ensure the efficiency of this working group. And the real objective that I was given in this briefing was, don't save lives, don't lose patients, prevent people from dying in their homes. Nobody should not get the care in their homes. Everybody has to get proper care. So we started by training personnel, we started coordinating everything. We had the ability, when we got a phone call of a difficult case, to send him to the intensive care immediately, not even passing by the emergency unit or the outpatient unit. We were really an important player, because you had in your hand the ability to tell the patient, stay at home and we'll take care of you, and making sure that he puts his trust, or she would put her trust and her life or his life in your hand, or take the serious patient all the way to the ICU immediately without having to pass by anything in the middle. And how did we do that? We had 130 stations, 130 seats, as we call them sometimes. And they were run by medical students in the last 2 years of medical school, supervised by eye doctors, not by any specialist. And we were receiving calls, we were orienting patients to go there or in this position or that position. And we were calling patients that were auto-isolated, and we were doing audio-visual contact, so we were seeing them. And they were seeing us, and we were discussing the case, and we were looking at their respiratory rate, and we were looking if they can continue the sentence, and we were looking at their oximeters for people who had oximeters, and we were asking for temperature. That is on a daily basis. At one point, we had to cover for 5,000 people that were at home at the same time, and we were running with those great champions and heroes that you can see that they are in their early 20s. And we were also the reference for general physicians. So we were also getting questions from all general physicians in Geneva about specific questions, testing, sensitivity, specificity of certain results. Now, we had 130 for 500,000 people. As far as I understand from the Ministry of Health in Egypt, there is 500 for 100 million. So the ratio is 1 to 3,000 versus 1 to 200,000. I think these are figures to be pondered. We also had access to 2 helicopters, and we used these helicopters to actually fly in patients from France and Germany when France and Germany were flooded, and we brought them back to Geneva for care. From the COVID call, we had 2 spin-offs. First was the COVID check, where we could send teams into the houses of people with real-time PCRs, the device that is smaller than a printer now, a computer printer, and they can do on-site in less than 30 minutes a result of the PCR in the house of the patient. So the patient would do the test and we will immediately know the result. You don't have to wait for a day or 2 or anything like that. And then there was COVID Care. It's another spin-off from COVID Call, where we used doctors from Médecins Sans Frontières, from the Geneva Emergency Network, where we could send doctors to care for patients at home if there was a need to do that. So let me remind you, my briefing was don't lose patients, don't lose lives. And the result was very simple, 0. We had 0 patients dying in their homes. We had 0 patients dying between their homes and the hospital. Obviously, there were patients that died after they went to the hospital, but we had 0 patients that died. And for me, this is a huge recompensation. It's an incredible satisfaction that I had a small role in something as important as that. Now, where is Switzerland? This is the number of cases, the total cases, and you can see we have a clear plateau. We can't get a better definition. And Professor Meteini spoke about the bell distribution. This is the bell distribution where you peak and then you go down. So we peaked in early April. By the end of April, everything was going down. And also it's important that I tell you how the government handled that. In the 24th of April, they came to the population and said, we are going down, so we can start to open. Nobody opens if we're going up. So we're going down, we're going to open, and we have a 3-stage plan. The first stage started on the 27th of April, where doctors' offices, dentists, hairdressers were opened. On the 11th of May, most shops and schools were open. On the 8th of June, universities, libraries were open, zoos were opened, and sex workers were allowed to continue with their activity. Now, we are back to normal in Geneva, but it's a new normal. The whole idea of social distancing is still in the mind of people. So people, they queue, but they queue with a distance, and people are still observing all the advices that were given by the government. Where does Switzerland, lie into this huge planet or global experience? According to a new study that was published in the Wall Street Journal a couple of weeks ago, Switzerland lies on the top of the pyramid in terms of which country should you be to be safest from the pandemic. And I would like to discuss very, very briefly something that comes to mind is there has been a lot of discussion about the Swedish model This is Sweden in the third tier of countries, where Egypt lies as well. And it is interesting to know that this is Sweden now. They have not peaked yet. They're still going up. This is Sweden and Switzerland today. 13 cases in Switzerland, 1,481 cases in Sweden. The only way that you reduce the burden of this pandemic is to be aggressive. And the only way I know that we know of that is to close, is to actually bring everybody in their homes and close somehow or another. Because if you continue to keep everything out, you can end up like Sweden. Is that a success? Well, if it is a success, it relies on the government timely and logical intervention. We used all our resources, private and public, different from many other countries. The civil society helped. There is a pragmatic culture of awareness and discipline among the Swiss people. And we have to agree that this helps a lot. People listened and people actually were very conscious about how to manage that. This is the ex-president of Switzerland, who is now the Minister of Interior. And he was one of the main players in that. And he was really one of the faces for the pandemic for us. He was the president of Switzerland a few years ago when he was 45 years old. What could we have done better? We started with confusing statements about being it's like a flu, and they were telling doctors, well, you don't have to wear masks. And that delayed our state of emergency till mid-March. If we had started earlier, could we have saved more lives? Time will tell when we look deeply into lessons learned. There was in the beginning shortage of masks and hand disinfectants and PPEs. Up till now, there's no compulsory rule on masks for public, but to the benefit of everybody, and we really have to be merciful when we judge ourselves. This was a very fast and very high curve, and we were all learning on the job. From a personal point of view, it gave me a fantastic opportunity to go back to basics as a generalist, not as a super specialist. It was a learning experience to learn so many things and to work with many teams. It heightened my senses of looking around the world and listening to sounds of birds and rays of light and the rainbows and looking at them in a different way. And it improved my appetite, not just for food, but for life, for research, for my work, for going back to my operating theater. I'd like to finish by acknowledging the University of Geneva and the University of Geneva hospitals, all the heroes of the 144, that 144. And I dedicate this to my dad. This is a photo in 1974 in Ayoun Moussa, where my dad took me to explain what is our country, what is patriotism, and how to manage the enemy. With that, I thank you very much for your attention, and I hope that this was not terribly boring. Thank you very much.
Thank you, Professor Tarek, for such an interesting presentation, and thank you, Professor Mahmoud, for such an interesting and informative presentation. Now we will start the part of questions and answers. The first question will be for Dr. Mahmoud. What's your expectations for the pandemic in Egypt in the coming weeks? And do you think that the current plan of facing the pandemic is enough and scientifically based?
Well, this is a very critical question. And what do you expect? All the expectation around the globe has failed, not only in Egypt, but everywhere. And as I said, the data are conflicting. And even Dr. Fauci, if we consider him in the United States as an authority of infectious disease in the world, he said that from the very beginning, and he's keeping saying that every day we are learning, and every day in the terms of the new data and the new emergence, we plan ahead for the coming days and weeks. But broadly speaking, we expected that June will be the worst month since the beginning in February, and I think now it's materializing. Now we are in the peak. We believe that we are peaking now for the past 2 weeks and the coming 2 weeks. July, we hope things will start to flatten and to be better, but a lot of things has to be done, and a lot of concerns must be very well tackled. As Tarek just mentioned about locking, we never made a total lockdown. We heard that in Switzerland there were no curfew and no lockdown, and I think thanks to the 100% literacy and thanks to the social and economic level in this country, you don't need to do curfew where people like the Swiss live. But in our country, we did a partial lockdown. We didn't do a total lockdown, and this is very understandable and justified because of obvious reasons. On top of it is the economic concern and the daily earning of life. And are we going to leave people to die from the disease or from infection, or leave them die from starvation? And this balance is very critical and very delicate and very, very difficult to have an answer for it. Even in the rich countries, you can see the United States striving to reopen because of the economic problems there and the jobless numbers and everything. So back to the question, what is the expectations? The expectations is another 2 to 3 weeks, hopefully. Very cautious and very prudent steps in reopening the economy. We don't have to rush into that, especially this week and next week, for example. Test more and more, and I think we started already that. Trace the population well and isolate. And if, I don't know, the second part, are we tackling in a scientific way? Again, this is a difficult question because there is no standard of care in this situation, even in rich countries. It's a totally new situation for everybody that surprised all the medical community and the whole planet. So we set the rules, we learn from from others, and we try to copy some experience here and there, and we try to ameliorate our practice day after day.
Thank you, Professor Mahmoud. The question is for Professor Tarek. Reference to what's going on in China, do you think that there will be a second wave in Europe?
That's a very interesting question. A second wave is probably on the horizon. We are thinking of winter and thinking that winter is coming, quoting from Game of Thrones. Everybody has heightened expectations and worries about what is going to happen. A big game changer might be the introduction of a vaccine. We hear about multiple vaccines in production, and we read a couple of days ago that the European Union had bought 400 doses from a certain company of vaccines that they would like to apply soon. These are in production. Would that come in time to prevent a second wave? Too early to say. But judging by historical precedents and what we know about pandemics, there's no way at this point of time that we say that we will not have a second wave. Everything points to the fact that the second wave would be coming, and the only game changer would be a vaccine. We think we gave up on finding a magical treatment for cases. Anything that was available now can help, might help, but is not something that will prevent or stop this pandemic. Remember that even a flu changes and mutates, and common flu changes, and every year we have a different vaccine. So it is very, very hard to imagine that this is behind us forever and that we can live happily ever after. I think we have to prepare, learn from what we have seen, and all of us, all countries have to prepare together for the worst. If we continue to play as isolated islands within continents or within even the same country in some cases, then it's no good. We have to prepare ourselves for a second wave that unfortunately is probably coming.
Thank you, Professor Tarek. Professor Mahmoud, what measures have been taken to overcome shortage of medical supplies due to supply chain interruption?
A lot, actually. Now, as you know, that there is هيئة الشراء الموحد, that which is how do you say it in English, the single authority for medical supplies, managing medical supplies for all over Egypt, whether university, Ministry of Health, private, military, and everything. And I think it's a very strong body that just started. So they helped us. And negotiating with all multinationals and all suppliers to try, with very intensive meetings. And I think they did all what they can. We had some at the governmental levels, I think a lot has been done by the Ministry of Health and higher than the Ministry of Health in terms of nation-to-nation help, and nation-to-nation, for example, with China, with India, we also helped other countries, as you witnessed that with by sending some PPEs to Italy and elsewhere. So a lot has been done, and I don't think that we had a real shortage that affected the practice. Yes, we were concerned all the time. Yes, the red flag were raised some hours and days, but it didn't last long, and the problem has been solved very rapidly. PPE, the civil society played a huge role, and I have to thank the civil society, and I don't want to, because all civil society, you can name it, صندوق تحيا مصر, مصر الخير, Sawiris, they all helped, others as well, supplying PPEs for us and for different institutions in Egypt and in Greater Cairo. So I think everybody tried to work together in this past to solve and to guard against any deficiency in medical supplies, on top of which is the PPEs.
Thanks, Professor Mahmoud. Professor Tarek, if WHO had, the participant is actually wondering if WHO had a good influence on Geneva control plan of the pandemic, or it was based mainly on local government at Geneva?
No, it's a very clever question, and I think it's really an intelligent question. WHO is based in Geneva, but we listen to the WHO like every other country. We are part of the WHO as member nation, but we don't, and we listen to advices from the WHO, but it is not a law. They're not religious dictums that we have to follow. In many instances, we went against what the WHO said. So there was the decision-making process was a federal and local decision-making. WHO gave advice to Switzerland, just like it gave advice to America, to Egypt, to India. And that's why I'm always a bit, unhappy when people say, but the WHO said, and if you don't go with what the WHO said, then you are committing a crime. No, because the WHO gives you advice, but what you have to apply this advice according to your own condition, to your own circumstances. We are not there to follow orders coming from a divine authority of the WHO, with all due respect to the WHO and its leadership and its experts. But every country has to fend for itself and has to look at these advices and basically apply them to the best of their ability and to the best of their circumstances. So the short answer was WHO advices helped, just like it helped everybody around the planet. We did not always follow what they said. We followed what we thought was good for us.
If I may elaborate on this, the question was a tricky question because the WHO exists in Geneva, and maybe they blessed you more than others. I think not, and I agree with what Tarek just said. But the question, just a continuation of the question, and I'm questioning the audience here, and Tarek and Professor Ashraf Hatem, did the WHO did a good job in this crisis or not? Because I'm raising this question.
If I may try to answer that, Dr. Mahmoud, I think it is too early at this point of time to judge if they have done a good job or not. We have to wait a little bit, and we have to get out of this black tunnel where there are many countries still. You look at the numbers in Brazil and you just have to cry. So we need some time before we have the wisdom of hindsight to look at what they have done and to look at all the decisions and the time of every decision. Remember that, I remind you all that we are dealing with a disease that we know for only 6 months. It's not cholera, it's not malaria, it's not typhoid. It's something that is so new. And only with time we will look back and see at what point we got what advice and was that good or not. But I think, to be very honest, I don't think that we can judge the WHO at this point of time. And to be very frank and very open and honest with you, Dr. Mahmoud, I don't think it's important. We really have to go ahead and solve this damage or this catastrophe that is affecting where thousands of people are dying every day. I'm not in the business of, I'm sure you agree with me, we are not at this point in the business of pointing fingers at the WHO or at our local governments and saying that they do right or wrong. We just need to get things done at this point of time. I don't have an opinion about if the WHO was good or not. I leave that to history.
Okay, thank you, Professor Tarek. Thank you, Professor Mahmoud. And now we came to an end to our session. Thank you, professors, for such informative and interesting presentations. Hoping that all our participants enjoyed the webinar and hoping that they will join us in the upcoming webinars of the healthcare track on the 25th of June and on the 2nd of July. Thank you so much.
Thank you.
Thank you.
Thank you, Heather.
Bye.
Thank you. Bye.